Namaskar. Good afternoon. On behalf of Department of Community Medicine and School of Public Health, PGI Chandigarh and UNFPA, I invite you all in the fourth webinar under the webinar series organized by these two organizations. So in the today webinar, we have two topics: managing gender-based violence during COVID-19 pandemic by Mrs. Anuja Gulati from UNFPA Maharashtra. And the second topic is dealing with mental health and psychosocial issues associated with COVID-19 infection. This session will be taken up by Dr. Sandeep Grover, who's a professor in the Department of Psychiatry, PGI Chandigarh. So I would like to invite first Mrs. Anuja Gulati from UNFPA to start the session on managing gender-based violence during COVID-19 pandemic. Thank you.
Thank you, Madhuji. Good afternoon, everyone. I hope all of you and your loved ones are safe and in good health. Today, we will be discussing the role of health professionals in addressing violence against women and girls, specifically in the context of COVID. Every individual has the right to dignity, optimal growth, and a life free of discrimination and violence. In spite of this, violence against women and girls continues unabated in our society. Violence is a manifestation of historically unequal power relations between men and women, which has led to discrimination against women by men. Violence denies women the right to survival, well being, and development. Yet, the fact is that most violence occurs within the home and within the most intimate and trusted relationships, because of which women continue to suffer in silence and often hide it. In spite of this, violence is a very critical public health issue and a major cause of death and disability, adversely impacting the physical, mental, sexual, and reproductive health of women. Because of this, health professionals have a very important role in addressing the issue of violence in women's lives and providing support, care, treatment, and referral. Kiranjiji, can I have the next slide? And can you please put it on slide projection mode? Can you put it on slide projection mode, please, Kiranjiji? I think we need to go to the previous slide. If you have an issue, just before we begin, I would just very, very quickly like to define what violence is. While most of us might be aware, gender-based violence is any act of violence that results in physical, sexual, psychological harm or suffering to women, including threats of such acts, coercion, or arbitrary deprivation of liberty, whether it occurs in public or private life. The next one, please, Kiranjiji. We have seen that violence against women and girls has known to surge every time there is a humanitarian crisis, whether it's an earthquake or floods on a very large scale or epidemics. Can I have the next slide, Kiranjiji? And there are reports of specifically domestic violence coming in from all across the world. In India, the National Commission for Women has said that there have been several instances of women calling into their helpline to report about domestic violence and seek help. On the other hand, there have been several NGOs that have said that actually the number of calls coming into the helplines for women seeking support for violence has actually gone down dramatically. Or they have also said that people do call in, but calls drop. So this is probably because women want to seek help, but they're not able to talk. They're not empowered to talk because probably the abuser is with them. Kiranjiji, we need to go to the previous slide. So let us see, why is it that there has been a surge in violence in the context of COVID, or how is it that violence has really gone up? the previous slide, Kiranjit ji. Otherwise, I can do a screen share if that's okay with you. The next one. Yeah, thank you. So the first reason why the surge in violence is because of the increase in caregiving responsibilities as a result of the lockdown. It's not only household chores that women are, being forced to do, but also the pressure of caregiving responsibilities with schools, Anganwadi centers, residential hostels, etc., closing down, children being at home. The caregiving responsibilities on women have gone up manyfold. They are also involved in care of the sick, the elderly at home, and this can lead to friction at home and result in domestic violence. Another reason is the financial stress because of compromised access of women to jobs and livelihoods. If you see, a very large percentage of women work in the unorganized sector, they are migrants, and they are the first ones who have lost their jobs, which has resulted in violence at home. Intimate partner violence also occurs because the woman may be stuck within the house with an abusive partner, and also because she has no autonomy over her sexual life. There have been several instances of economic violence against women, where women have been denied basic essentials like food. I mean, there have been helplines where women have called to say, I'm not even given soap in these times, and that's just a way to torture me, to trouble me, during this time. Also, there's been large scale displacement of migrant workers, including women. And, when they go back to their villages, these migrant workers face a lot of stigma, discrimination, and women may face violence because of various things. One, because the general community feels that they may be bringing in infection, it may be because of caste, religion, etc. Also, we've seen a lot of violence, especially verbal abuse, increasing with the health staff themselves. This is probably, at the hands of frustrated or overwhelmed families, where patients are suffering from COVID. In addition to all this, the one critical thing is that women lack access to protection services. They're not able to seek support services, whether it's in the form of professional services like those they can get from one-stop centers, or it is the support services that they themselves can get from their families, their well-wishers, friends, etc. And also because they hesitate in reporting violence as a result of privacy, because they are confined within the home and probably with the abusive partner itself. So we see, and we can go to the next slide, Kiranjit ji. Violence thus impacts the physical, mental, sexual, and reproductive health, and has severe fatal and non-fatal consequences. The fatal consequences could be, can I have the next slide, Kiranjit ji? So the fatal consequences are in the nature of maternal mortality, etc., going up. And the non-fatal consequences could be physical bruises, cuts, wounds. There could be mental, severe anxiety, depression, post-traumatic stress disorders, etc. And they could also be sexual in nature, unwanted pregnancies, etc. We have seen, Kiranjit ji, you will need to change the slides, please. Otherwise, I can start screen sharing from my end. We need to go to the previous slide. The previous slide, please.
Yes, ma'am.
We've
Just a
seen that
second.
data from the National Family Health Survey 4 has shown that about 1 in 3 women, to be precise, 31% of women in the 15 to 49 age group, saying that they have experienced some form of physical or sexual violence from their intimate partner or spouse. And what are the impacts, the health impacts of this kind of violence? If we see, intimate partner violence is known to increase health related impacts dramatically. It can impact, it can have injuries on the body of women. In fact, about one third of murders committed on women are those committed by their intimate partners. About 16% of women face various other consequences in terms of injuries, etc. So that is the impact of intimate partner violence. What is the role that the health sector can play in dealing with survivors of violence? Very, very important, because health sector is probably one of the most important entry point for women survivors of violence, and is also probably the first professional contact for women facing violence. Because when they hurt or when they have a physical or mental consequence, the first place that they approach is a health sector, or is the hospital or the health professionals. Health professionals are hence strategically placed to identify and help women survivors of violence. The next slide, please. So, what is it that a health sector can do to address violence in the lives of women, or what constitutes a comprehensive health sector response to violence? The first thing, and especially in the scenario today, is to identify survivors of violence. The second is to provide care and treatment. And here I would go into three aspects. One is providing first line support. Two is examination in case of sexual violence. We are not going to touch that today. The third aspect is, assessing their mental health, providing psychosocial support and counseling. The third very critical thing is documentation. In case of domestic violence, or domestic incident report. In case of sexual violence, or medical legal report, because these are very critical documents that would help women get access to justice in the long run. And the last is how women could be linked to services that they require, referred to services that they require. If it's, for health services, to higher levels of institution. If it is other social services, it could be services in the nature of shelter homes. It could be services in the nature of legal aid. For children, it could be referring them to child welfare committees, etc. Can I have the next one? Here, I've the next slide, Kiranjit ji. I've tried to look at two examples.
I suppose there is a problem with the internet of Kiranjit. If
Okay, can I then start my
yeah,
screen
yeah,
sharing? If
Yes,
that's
ma'am.
Kiranjit,
okay, and
please
I'm very
stop.
sorry.
Yeah,
I apologize for this. We will just take a minute and I'll start my screen sharing.
yeah. Kiranjit, please stop your screen share.
Yes, ma'am.
So, these are certain examples. For the last 24 months, uh, there's this 24-year lady who's been coming to a community health center every 2 to 3 days with complaints of weakness. She says she's feeling tired and absolutely not interested in work. The staff at the center give her vitamins, they give her a tonic, and they send her back each time. 2 weeks after the lockdown started, she's brought to the hospital in an unconscious state with her wrist slit. And her husband is by her side. He just does not want to leave her. This is another example. This is the example of a 29-year-old girl who's been just married for about 2 months. She calls you because telemedicine is permitted. She calls you with complaints of severe stomach ache. You prescribe her medicines for acidity. She calls you, a couple of times. You've got her phone. She's called you. Her call drops. She again calls you a little, maybe a week, 10 days later. She again says, I have severe stomach ache. But this time she says, I also have severe body pain and my nose is bleeding. Can you prescribe some medicine? And then she quietly tells you she's also missed her periods and does not know what is it that she has to do. Go to the next slide. So, as doctors, these are instances where we need to try and understand that yes, these had certain aspects, or there were certain red flags which could have helped us identify that this particular client or patient was a survivor of violence. What are these red flags? A woman who comes with multiple injuries in sites that are usually covered with clothing. She's got several injuries, but she's always trying to hide them. A woman whose partner is always close to her partner or maybe her in-laws, because they always want to understand what she's trying to tell you. A woman where there is evidence of strangulation or the neck, fractures to the upper arm. It could be a woman who's very, very anxious, reluctant to provide any information about how she was injured. A woman with history of psychiatric symptoms such as depression, suicidal attempts, self-harm. She could have tendencies of substance abuse. A woman who comes to you or calls you in with saying that I keep falling down, I've had repeated accidents. A pregnant woman, with injuries to her breasts, genitalia, or abdomen. A woman who tries to always conceal the identity of the perpetrator. Women who may be brought in semi-conscious or unconscious conditions. And generally, such women tend to get discharged against medical advice. And the time lapse between injury and seeking treatment is very long. Well, having identified what are the principles that we would use to provide care, I think the first thing is to have a rights-based approach. The survivor should be made aware of her right to emotional, physical, and sexual health, the fact that she has a right to a life free of violence. The second is gender sensitive approach. You need to be very, very sensitive in dealing with a survivor, trying to tell her that she has the right to a violence free life. And not just that, the fact that any kind of violence is not her fault, whatever she may have done. She has a right to bodily autonomy and integrity, and that whatever services she wants, you know, the entire services would be based as per her needs and as per her consent. The third important thing while providing care is to ensure that whatever you or however you deal with the woman, it is done in a culturally sensitive manner. The language you use, the kind of tone you use, the words you use are some kind of words that a woman understands. Also, if it's a child, the entire nature of providing services, questioning the child will completely change. When I talk of a survivor-centered approach, it also means that the survivor's rights will be prioritized. Survivor may have several rights. She may want immediate protection. She may want to be taken out of the house, and as a doctor, she calls you. Can you link her to, a protection officer who can help her to do that? Either move her to a shelter home or get assistance from police and move her to, a well-wisher's house, a parent's house, or wherever feasible. She may have emotional needs. She may say that I'm extremely depressed, I'm anxious. How is it that you can counsel her, you can provide her psychosocial support? Still, if she has tendencies of self-harm, how you could refer her? Or she may have physical needs, like I said, she has a bleeding nose. How is it that that can be treated? What is it that you can do? The other thing is to never justify the violence. Always tell the woman that, you know the fact that she's been violated is not her fault. Whatever you do in terms of addressing a survivor's needs, in terms of examination of a survivor, please ensure that consent is taken. And consent is informed consent in a language that the woman understands. Anything done outside taking her consent is illegal as per the law. And in fact, very, very clearly, in cases of sexual assault, if a woman does not give consent, you cannot proceed with anything. Also, midway, a woman can say, I do not want to progress, so you will need to stop then and there, if even if it's in the middle stages of an examination. Other thing is to ensure privacy and confidentiality. While telling her that everything that she discusses will be kept confidential, you also need to inform the survivor the limits of confidentiality. confidentiality, because in cases of sexual violence, mandatory police reporting is there, and you have to mandatorily report to the police. Of course, if a survivor does not want it, then informed refusal has to be documented. A survivor should be given access to all the information that is being collected, her medical records, etc. You need to tell the survivor that she will not be harmed by the disclosure and she can trust you completely. And now we go on to having, identified the red flags. How is it that, you will definitively say that, yes, this is a survivor of violence? There are two ways to identify survivors of violence. One is based on universal screening, and the other is based on identifying her clinical conditions. The clinical conditions are very similar to the red flags, but listed here are some of the clinical conditions like symptoms of depression, anxiety, tendencies of self-harm, suicidal tendencies, maybe substance abuse of some kind, unexplained gastrointestinal symptoms, reproductive symptoms including pelvic pain, sexual dysfunction, etc., repeated vaginal bleeding, repeatedly coming to the hospital or talking to you for sexually transmitted infection, chronic pains which are unexplained, traumatic injuries, you know, and consultations with absolutely no clear diagnosis. So based on these clinical conditions, you can identify a survivor. Universal screening is not suggested by WHO because of the very, very heavy load on our health system. Once you have tried and identify, the next step is to probe and ask certain questions. So again, while probing or while asking questions about violence, please ensure the survivor of confidentiality. Please ensure this, that when you're questioning the survivor, it is in a private place. Do not ask questions in public, and tell her that all the information that she is giving will be confidential. How do you probe? So initially you could just have general statements like, many women experience problems with their husbands or partners they live with. Do you have any such problem? Or a generic statement like, violence is a common feature in the lives of many women, and hence I would like to ask you some questions about the same. Having probed, you could move on to more discrete questions, and these could be in the nature of, has your husband or partner or someone else at home ever threatened to physically harm you in some way? If so, when did that happen? Or does someone bully you? Is someone very sarcastic? Does your partner try to control you, does not give you access to basic essentials, money for basic needs? So several of these very, very simple questions can be asked to probe about violence. If a survivor does not acknowledge violence, do not pressurize the woman. Give her time to decide what she wants to share. Even if you're on the phone and you suspect, it's a telemedicine call, and she's called into you to say that, I have a wound, and I have a wound, I have bruises. What do I take? You try to question her, but if she does not want to say, do not pressurize her. Tell her that she's free to call you at any time. Tell her that violence can have an impact on her health, on the health of her children, and ask her to call in again if she wants your services. Try and say, okay, call me back 4 days later, call me back 3 days later. So fix a follow-up visit or a call. Try to see that it's not just left, even if she does not want to acknowledge violence in the first go. Give her the space to open up. Once you have identified, the basic thing is to provide first line support. First line support is to listen to her with empathy and without being judgmental. Identify the survivor's needs and concerns. Like I said, she may have a range of needs. So identify that and see how these can be handled. You may need to refer her to several places for this. You could do that. The third thing is to always validate what a survivor is saying and not blame her. Because once you validate, you are getting reassured that, yes, this is exactly what the survivor wants to communicate to you, and your entire approach will be survivor centric. The other thing is to try and tell her that, what are the ways in which she can protect herself. try and help her develop a safety plan. Tell her to recognize the pattern of violence and to remove herself if that pattern is repeating. Also, you may like to just very casually tell her, see, I do know that you are facing violence, and in case there is an unforeseen situation and you have to leave home, keep your important documents like your identity proof, maybe some of your educational certificates, some money, etc., with you, and carry them if you have to leave home. Also, the most important thing after this first line thing is to provide her with immediate care and treatment. Care and treatment could be range. It could be treatment of injuries. If it's a case of sexual assault, then there's a completely different line of treatment. It could be emergency contraceptive, depending on when she has reported after the incident of sexual assault, or PEP, etc. So depending on her need, what is the care and treatment that she requires. Well, having done that, the next critical thing is to provide a woman with psychosocial support and counseling. You need to explain to the woman survivor that a stressful reaction is there whenever violence happens, and she's likely to feel better with time. Uh, and if she receives emotional support, things will definitely improve. You could help the survivor strengthen her positive coping mechanisms by building on her strengths. Tell her, oh, you have a very good degree, you have so many support systems in the form of your friends, your well-wishers, etc. Make her explore her support systems on her own, help rebuild her self-esteem. Try and teach her very small, maybe stress reduction exercises, which you could do face to face, or even if it's telephone counseling. Try and understand if she has thoughts of self harm or suicidal tendencies. If she has, you have to deal with them appropriately. Maybe you could refer her, you could link her to further support, and if she requires counseling, refer her there. Very important, like I said, to undertake documentation, because a detailed documentation of the history of the examination you have conducted, especially in cases of sexual violence, and I'm not going into the details, the consultation that was given will provide very, very crucial evidence in the court of law and would help the survivor in the long run. If it's a case of domestic violence, you will need to fill a domestic incident report and forward it to the protection officer. In cases of sexual violence, a complete medical legal documentation will have to be undertaken. And lastly, the kinds of referral and linkages that are required for a woman survivor, you need to understand those. Maybe have handy certain telephone numbers, which most hospitals do have. If she needs medical assistance, and it cannot be given at the facility you are, refer her to higher medical facility. If she needs protection or wants to file a first information report, link her to the police. She may require social services in the form of a shelter home. She may require counseling services. You could refer her to a one-stop center. And she may require legal aid. So, across the country, legal services authorities are open to provide. They've been considered as essential services and are open. In fact, very recently, the government is now contemplating having the services of protection officers also considered as essential services. Some states have already done it. You could try and link her to all these services. I think I will stop here because my time is up, and we can take questions later on. Thank you so much.
Uh, Thank you, Mrs. Anuja. That was really very informative talk, and very emphatically you have mentioned about this topic. And I would say, yeah, I mean, as a service provider, even we also tend to miss out cases. And with your talk, it seems that we should be probing more about these cases. So I'm sure there will be questions, and I request all the attendees who have registered to post their questions. You can type it in the question and answer section. For the next session, I would like to invite Dr. Sandeep Grover to speak on dealing with mental health and psychosocial issues associated with COVID-19 infection. Thank you.
Uh, Thank you, Dr. Madhu, for inviting me to speak here. I'll be basically focusing on the psychosocial issues in relation to pregnancy and postpartum, because that is the basic theme of this whole webinar series. So I'll be presenting my talk in three basic parts. That is, first I'll be discussing what are the mental health and the psychosocial issues among pregnant and postpartum women, and how does COVID-19 pandemic add to these problems, and what we can do to address these problems. So let's first understand what are the mental and health and the psychosocial issues in women who are pregnant and in the postpartum. Basically, we need to understand that pregnancy and postpartum brings in a lot of stress, and this stress can arise due to planned, unplanned pregnancy, or thinking about the gender of the child, changing the role in terms of family, work, and many women go on to develop psychiatric disorders. Substance use is increasing in our society nowadays, and we have a lot of relationship issues which are emerging. And usually, women also worry too much about the pregnancy and the newborn because of what would be the outcome. And when we look at the psychiatric disorders, although we classify psychiatric disorders into very different categories, but most commonly what we see in women are that in the antepartum period is depression and anxiety, and about 1/8 of them will go on to develop depression or anxiety disorder during the antepartum period. And in terms of worries, basically they arise because of the changing roles in their life. That is, how they're going to become a mother, how is that going to influence their working life, how is that it is going to influence their relationship with their spouse and other family members. And they will always doubt about being good parent, bad parent, and so on. And out they will worry a lot about the outcome of the problem, what is going to happen in terms of pregnancy outcome and so forth. And there is a lot of fear, which we call sometimes as tocophobia, of pain during delivery. So that will be again another source of worry and anxiety. And many women nowadays are staying away from the spouse, so there is lack of support and being alone. And because the pregnancy is associated with a lot of change in the body shapes, it leads to a lot of psychological issues. So the risk factors for depression are usually if the mother is to be mother is a very young woman who is having an unplanned pregnancy, the primipara, and there's past history of stillbirth or spontaneous abortion, or there's history of pregnancy-related complication, or there's history of obesity and presence of any chronic physical illnesses. In terms of psychiatric issues, I think there's a host of issues. If the woman has personal history of depression or any mental illness, or there's a family history of substance use, childhood trauma, anxiety traits, or anxiety in any form can lead to development of depression during the pregnancy. And in terms of social factors, again, domestic violence, having a lot of psychosocial stressors and lack of support from the family, history of child sexual abuse, and poor attachment to their own mother, and especially those who come from low socioeconomic status are more prone to develop depression during the antepartum period. Studies which have come from the eastern part of the world, that is like from India, they suggest that there are a lot of relationship issues with other family members, mainly the mother-in-law, and it's a nuclear family setup. Like more and more now we are moving towards the nuclear family. That is also a risk factor for developing depression during pregnancy. So what are the symptoms of depression? I think I need not to say that the depression is same as we see in other age group. It may manifest as sadness of mood, tiredness, negative thoughts about self, irritability, anger, difficult to handle the situation, anxiety, and ideas of hopelessness, worthlessness, or suicidal ideation, and so forth. And especially in antepartum period, the woman may not take care of her pregnancy as much, do not take care of their antenatal visits and so forth. So if as a clinician, when you are evaluating a woman whom we should be suspecting as she may be having depression, that somebody who has a history of not eating well, not gaining well during gaining weight properly during the pregnancy, reports of sleep disturbance, is often missing the prenatal visits, and does not follow the instruction using substances, or there are problems during pregnancy or delivery, or we are seeing that is a low birth weight baby during the ultrasound and other things, or there's premature rupture of membrane. All these are indicative that woman may be possibly having depression. So if we don't know how to recognize the symptoms of depression, also these features should alert a clinician that maybe I should be evaluating or at least seeking a psychiatric consultation for this woman for depression. In terms of postpartum psychotic syndrome, we basically understand that this can be broadly divided into three parts. That is postpartum blues, postpartum depression, and postpartum psychosis. Postpartum blues are very, very common, are seen in about 50 to 85% of the mother in the first 2 weeks. These are short lasting. And what we can see is that about 1/8, as I already said, will have depression, and very small proportion will have psychosis. The postpartum blues are basically manifest as irritability or fluctuating mood, and there is increased emotional reactivity, but this is limiting and subsides within 2 weeks. Whereas depression, I have already alluded that what kind of symptoms we are going to see. And psychosis, they will have psychotic symptoms like delusions and hallucinations, and which is a more severe condition. When we look at the prevalence of depression during the postpartum in India, when we compare to the Western literature, the prevalence rate in India has been varied from 9 to 35%. They are slightly on the higher side. And the symptoms, again, as I've said, that if as a clinician you are evaluating the mother in the postpartum period is reporting disturbance of sleep, anger, or crying frequently, or having emotional lability, not able to concentrate, not able to have food, or reports a lot of anxiety in relation to child's health, I think you should be missing out on depression. So that is where a reevaluation is required. Then the other manifestation which can be there in women with postpartum depression is that they can have bizarre thoughts about harming their child, or they may be feeling overwhelmed, or they may not be able to bond properly with their baby, or they may be always having frequent thought whether they're bad mothers, they're not able to take care of the child, and they will find motherhood as a lot of as demanding, and or somebody who avoids breastfeeding, or have a lot of guilt or extreme doubts about being the good mother, unable to take care of oneself and the baby, and there are excessive self concerns or the concerns about the baby's health. So these are the features which should alert somebody that we should be evaluating the lady for depression. The risk factors for postpartum depression are also almost similar what we see for the antepartum depression. And in terms of the socio-cultural factors which are more important in Indian context, we need to understand the stigma and unhappiness about having a female child, relationship issues with the partner and the in-laws, and lack of control over the finances and intimate partner violence, as previous speaker already alluded to, are the important risk factors for postpartum depression. Now let's understand what does COVID-19 pandemic adds to this so-called mental health and psychological issues which are already being faced by women. So what we are seeing in COVID-19, there's a lot of media hype, there's a lot of misinformation going on in the society. We all know that there's no treatment, and there's a lot of, this is leading to a lot of scare, fear, mistrust, and a lot of stigma. If somebody develops this illness or somebody contracts this illness, we are looking them with a different kind of a spectacle. Currently, what prevention or treatment we have is different hygiene measures, using masks, use social distancing, and we all are in the lockdown. So we need to understand these are the important measures which can help us to prevent or so-called stop transmission. At this moment, this is working, and this is working for everyone in the society, but it's taking a toll on the mental health of everyone, and it will have more problems for women who are pregnant. So what all we are going through, the fear of falling ill, we all are facing a lot of depression, anxiety. There's lots of livelihood, so we are worried about the finances. We are all scared of death. We are feeling hopeless, helpless. We are always concerned that whether we'll be quarantined. We are feeling socially excluded, lonely, and some people are losing their family members. People are dying, so there's a lot of loss of loved ones. This is what everyone in the society is going through in this pandemic. And what are the questions in everybody's mind? If I can say that if you ask me, do I have this question for myself? Yes, definitely for myself also, that whether I'll be getting infected, will I end up spreading the infection to others? Does somebody in my neighborhood or people who are coming close to me have infection? If I get infected, who's going to take care of me? Whether I go to the hospital, whether I'll get a ventilator or not? What if I'm going to die? Who will cremate me? What happens if my parents, my children, my spouse gets infected? These are the worries which all of us may be having, and we are looking everyone at our place who are around, or when we are suspected to have COVID-19, that somebody who suspected, his tests are being sent. So what they are going through, what if the test comes in positive? They're facing a lot of discrimination, that pamphlets are being pasted outside their house. There's a lot of social isolation, disconnection, loneliness. And what the people, when they develop any small symptoms like a simple sneeze, it may be taken as a symptom of COVID-19, and that leads to a lot of anxiety and panic. And people, those who go through quarantine, are again going through the similar kind of things, and a lot of symptoms, small symptoms, are being considered as indicators of the illness, and we are having a lot of obsessive thoughts about developing the infection. So that is again inducing a lot of anxiety. So all this is leading to a lot of social isolation, disconnectedness, loneliness, and we all are facing the fear of death. But at the same time, we are trying to survive this by possibly becoming addicted to the screen media, and we all are facing this stigma around all of us. And due to all this, what we are trying to now get adjusted to is a new normal world. And what is this new normal world? Is that there's change in the daily routine. There is closure of the favorite places like parks, movies, eating joints, malls, etc. So we are getting used to it now that we have to adjust to this. This may not open for some time. And we are maintaining social distancing. We are working from home, and we are trying to get adjusted to the new routine. Few people are facing loss of jobs, and we are all adapting to the new roles of homeschooling, working from home, caring for other family members, trying to fight off the feelings of social isolation. And at the same time, in India, we are so much used to our house help, so we don't have any house help available. And as the previous speaker talked about, that having the spouse at home is leading to a lot of interpersonal problems, domestic violence, sexual demands, and coercion. And this is also being faced by the pregnant women. And this is actually leading to a lot of distress and stress in these women, depending on the duration of the pregnancy. So what all does this mean to a pregnant woman? Like this COVID pandemic and what already they were facing. There's a lot of significant stress. The joyful time of pregnancy is now changed into an uncertainty and the fear of unknown. There's a lot of, we are people for last now 1.5 months. Initially, there was some amount of acute stress, but we are now moving towards some kind of a chronic stressful situation. So what are the additional psychological issues which are emerging in the pregnant woman? That they are fearing or they're scared of whether they'll end up transmitting the infection to their unborn child, or they have to change their lifestyle to adjust to the lockdown. They are worried about their antenatal care, whether they go to hospital, they may get infected. If they don't go to the hospital, the child may have some complications. They're going through that kind of a dilemma and ambivalence. And there is sort of change in plan of birthplace, because earlier somebody may be thinking that I'll go to say XYZ place. That place is not accepting deliveries now. So a lot of issues are again arising due to that, and that is again further leading to anxiety. And because of the social distancing and everything, there are issues about who is going to be there with the person during the delivery. And some women are contemplating termination of pregnancy, are worried about having malformed pregnancies, are not able to tolerate the pain, and they are saying that maybe that having a normal vaginal delivery is actually going to increase the risk of infection to the child, so they want to go for an elective cesarean section and so forth. Although these are misinformations in the society. And in terms of breastfeeding, again, there are a lot of issues about whether they should be feeding the baby or not, how much close contact they need to maintain with the baby, and what are going to do in terms of the child develops some problem, whether the child will be taken to the hospital or not, and what to do and what not to do in terms of visit to the hospitals. And in terms of people who are found positive for COVID-19, I think we all need to understand that anybody who is getting positive for COVID-19, they are going through this 5 or 6 stages of initial diagnosis, admission, coming in terms with their admission and the diagnosis, fear of progression of the disease if somebody requires an oxygen support or the ICU care. Then there's a lot of anxiety related to the pre-discharge testing. Then there's a lot of anxiety at the time of discharge, of stigma, and then the facing the society. So what does all this bring in? This brings in a lot of emotional changes like anger, fear, depression, and I just have listed all this. But additionally, for women who are pregnant, what does it bring in? That there's a lot of fear of transmission to the newborn, fear of infecting the newborn from their own infection, and apprehension of not being taken care of during the delivery, and discrimination which they may end up facing in the hands of the healthcare professionals. The other issues which have been seen, because we are seeing many people are getting together admitted, that families are getting admitted, there is a lot of blame game going on, who brought the infection to the house, and difficulty in meeting the demands of very young children if they are accompanying the parents, especially if the mother is pregnant. And the hospitals do not have the recreational or the creative activity facilities to keep young people engaged, so that again becomes a burden on the mother. And because the families are getting infected together, there's a lot of worry about the health of the partner, elders, young children, especially those who go into the ICUs. And the other issues, what if I die? Who is going to take care of my child? What happens if my child dies? Who's going to blame? Who's going to be blamed? Then there are a lot of issues about the cremation, religious beliefs, and the remains. These all are concerning all of us. Let's all agree to this fact that we all are facing similar kind of a situation. So how we can address these mental health issues in pregnant women at this time? I think the most important thing is we need to screen pregnant and the postpartum women for mental health issues, and we need to specifically inquire about anxiety related to COVID-19 infection. And if somebody has, they should be referred to the mental health professional for further evaluation. And we need to also inquire about how they are adjusting to this new normal, that staying back at home, partner at home, taking care of family members without having the housemaid help, and how does that affect their life. Then take the history of substance use, support available at home and outside, sleep, always inquire about suicide, any kind of sexual coercion being faced, amount of screen media they are using, and the domestic violence. I think we need to focus on these when you evaluating these women. And the signs which may indicate of high level of stress is change in appetite, frequent feelings of fears and worry about the pregnancy and the delivery, poor quality of sleep, there's problem in concentrating or fear of getting infected, avoidance to the hospital, or there may be history of frequent visits to the hospital, although when these are not medically indicated. So somebody who is coming to the hospital time and again, although not medically indicated, may be actually having a lot of anxiety and depression rather than any medical problem there. So how we can screen? We can use simple screening instrument, something like perceived stress scale 4 item. And if the person scores higher on this scale, the person maximum can score 20, 16. So if higher the score indicates higher level of stress. And you can also use PHQ-4, which has 2 items for depression and 2 for anxiety. So somebody who scores more than 3 for the depression items or more than 3 for the anxiety items, he possibly needs to be referred to a mental health professional for evaluation of depression and anxiety. For pregnancy, we have a pregnancy specific depression scale, which is known as Edinburgh postnatal depression rating scale. So again, same can be used in a score of more than 10, because each item is rated on a 4 point scale of 0 to 3. So if somebody scores more than 10, it indicates that the woman may be having depression. So that is where we need to be evaluating and taking calls whether the person requires a mental health professional consultation or not. Never forget the risk of evaluating so-called perinatal suicidality. This is usually common in young maternal age, especially who are unmarried. There's prior history of suicidal attempt or psychiatric history. There's family history of suicidality or the psychiatric history. Those who are facing domestic violence have poor social support. There is rejection of paternity by the partner, or there are unwanted pregnancies, or there's abrupt discontinuation of the medication during pregnancy. And during the COVID pandemic, I think what we need to understand, one more important thing, that these women may be having easy accessibility to the things which they can use to harm themselves, having simple things like sanitizer around or the sodium hypochlorite around. They may just consume this and harm themselves. So we need to be very, very careful when we are advising all this to this woman also. Then how we can help? I think the first advice should go to the family rather than the patient themselves. The simple things which we can tell to the family is that listen to the patient, be available, support, and be try to provide all kind of social support, psychological support, and share the responsibility at home, and or take up the responsibilities of the home from the pregnant woman if she is not able to manage. So depending on the woman's interest, responsibilities can be shared or totally be taken up by the other people in the family. And any kind of abuse should not be accepted, and they should be informed that there are legal provisions about this, and everybody should be very, very careful about this aspect. The general care, I think we need to focus on, we should always encourage women for taking proper nutrition, healthy diet rather than taking any kind of junk food. Whatever exercise they can do at home, maybe breathing exercises or aerobic exercises within their home or going to the terrace, and whatever they can do, that should be encouraged. They should be encouraged to have proper sleep, and they should have some time for themselves, and they should seek support from everyone in the family and should avoid any kind of substance so that they remain relaxed and comfortable. Then they can engage themselves in enjoyable hobbies and activities that will distract them from their anxiety of their pregnancy and other issues which are emerging. Maybe playing music, listening to the music, gardening are certain things people can choose for. Then avoiding too much of media. When I say too much of media, means listening to the updates on the news channels every minute, what is happening, number of cases, number of deaths, who got affected, who did not get affected, and so forth. Doing relaxation exercises and keeping a positive frame of mind is something which we require. And how we can then balance use of media, that we need to inform these women that they should follow the authentic sources to get the information, and they should limit the amount of news which they have access to, and they should not get fixated to the news channels, so that they do not get misinformation or do not get panic by listening to the news every minute what is happening in the country or the world. And we should correct their misinformation about COVID-19 infection and the consequences. We should educate them about the illness, which I'll be discussing later on. And we should address the queries of the patient, spouse, and other family members, and inform about the stress reactions which they are going through, how they can identify their own stress. So what we can advise them, I think this is well known to all of us, that avoid contact with people who are ill, have travel history, avoid unnecessary travel and going out, cover your cuff with your elbow, and frequent hand washing and everything, and social distancing to be followed, which is being generally recommended for everyone. But additionally, what we should be recommending is, we need to understand that there is a lot of media hype when people talk about social distancing. I say that this is a misnomer, because it is just a physical distancing. You should not interpret social distancing as an emotional distancing. You can always connect with your near and dear ones by using maybe phone, or maybe video conferencing, teleconferencing, whatever you want to do, so that you stay connected with people. Or at home, you talk to your partner and other family members, maybe maintaining a physical distance, so that at least you are able to talk and share your things. And encourage women to choose a person in their family who is prepared to listen to them, so that they can address and get some amount of relief from their anxiety. And they should also have some amount of non-COVID conversation time with family members and others. And they should, again, the conversation should not be just limited to the issues related to pregnancy and the postpartum. And they should connect to people, friends, family members. They should choose who are not trying to sensitize the things which are happening in the society, but who are prepared to provide them genuine support. What we require is mental hygiene, in the terms of teaching this woman and making them realize that there are some amount of real worries and the hypothetical worries. Real worry, planning for delivery when you're 4 weeks away from your delivery date, is a real worry which you need to address. But worrying about simple things like grocery is going to end and something is going to happen is an unnecessary hypothetical worry, and it is leading to a lot of anxiety. So we need to tell them that whenever you are trying to see that we are seeing that you have a hypothetical worry, press the pause button in your mind and focus on something else, because that is going to help. And as professionals, we need to provide them the factual information in terms of that pregnancy not associated with increased risk of infection of COVID-19. And at present, there is no information about the miscarriage or stillbirth or congenital malformation associated with COVID-19. Yes, we have some information about the previous influenza pandemic, so we need to give information accordingly. Vertical transmission is at present not being proved, and infection is not transmitted from mother to the infant through close contact after delivery. We need to understand that infection can be transmitted from mother to the infant through the close contact after delivery. And at present, COVID-19 infection is not an indication for medical termination of pregnancy. Then what we need to be again emphasizing, that if somebody is suspected of COVID-19 or has been having COVID-19, as healthcare professionals, we have to respect their dignity and also give them respect, irrespective of their having COVID-19 infection. Throughout the pregnancy, there is antenatal period, during the intrapartum period, postpartum period, and to the to the newborns, that they are treated with a lot of respect and dignity, and they are allowed to have the companions close to them when it is required. And the maternity team should support them so that they feel comfortable. And pain relief, again, we have recommendations for that, so that should be considered rather than avoiding the same. Regarding the breastfeeding, again, the recommendations are very, very clear, that breastfeeding is not just expression of milk. It is some kind of an emotional bonding between the mother and the child. So we need to be addressing that and understanding that it's an emotional bonding which is more important. And breastfeeding can be continued by taking proper precautions, and breastfeeding should not be avoided. If the mother is found to be COVID positive, still the express milk can be given to the child. And we need to take what are the 3 W's which have been said: that wear a mask during feeding, wash hand with soap before and after touching the baby, and wipe and disinfect the surfaces regularly. So if somebody is COVID positive, they need to take extra hygiene measures. And if they're using a cup and the spoon, again the hygiene measures should be taken care of. And breast pump should be dedicated to each mother rather than any kind of sharing of the pump. And those who are going to quarantine, again, we need to inform them that they can still remain connected with people by using telephones or internet and whatever measures they want to, and should not remain alone to overcome their boredom and isolation. And they need to follow a simple routine, but at the same time detoxify themselves from social media and take care of themselves. So when to refer a person to a mental health professional? When they screen positive for stress, anxiety, and depression. And nowadays, although people cannot reach to the clinics, teleconsultations are widely available throughout the country. And the decision to start psychotropic medication can be left to the psychiatrist. The Indian Psychiatric Society, which is the largest organization of mental health professionals, has started a free national helpline where 700 psychiatrists are participating in providing the mental health care free of cost. So anybody can visit to this website and get the list of the professionals available around your community so that you can get to talk to them. And there are fixed timings which can be followed when you can contact them and avail the services. I would at the end like to acknowledge all the members of my department, my colleagues in the institute, and all my patients and families, and especially my working team with whom I work in the department when I'm working in this whole COVID pandemic issues. So I thank you, everyone. Stay safe, stay healthy. Namaste. Thank you.
Thank you, Dr. Sandeep, for this lucid presentation, and many of our doubts are cleared. And you have given very good reference points that how to deal with the mental health and psychological issues among pregnant women and postpartum women. So, with this, we will start with our panel discussion. So, we have one question from the audience. That question is from Mrs. Anuja. Uh, if I request all the panelists to start their videos and audios. Yeah. So the question is the Nirbhaya fund to be used to address issues of violence among women? Mrs. Anuja?
Okay. Yes, the government has come up with a Nirbhaya fund, and the Nirbhaya fund is being given to various ministries. And the largest recipient is the Ministry of Women and Child Development. The fund is being used for various things like victim compensation scheme. It's being used for initiating one-stop centers for providing psychosocial and counseling support to women survivors of violence, etc.
Mhm. So that means it can be used.
Yeah, definitely, definitely.
Okay. So then I will move to another questions. So we definitely have a law in India for protection of women against domestic violence. This was one question. And what referral protocols are followed for first responders for victims of gender-based violence? So this was another question for Mrs. Anuja. So the protocols, I think you did present in your talk.
Yeah. So quickly, yes, we have a law in India to address domestic violence. You said it's called the Protection of Women from Domestic Violence Act. And this came out in 2005. It's a very, very interesting act. It defines various forms of violence: physical violence, emotional violence, economic violence, sexual violence. All are defined. A very critical thing that it covers all women. So whether it's a mother, whether it's a sister, whether it's a wife, whether it's a widow, or anyone who is living with a person and is a partner of the person. So it covers all kinds of women under it. And it gives women certain rights. The first right is that every woman has the right to be safe and secure. to live a life free of violence. The second, very critical and the most important thing that this law does is that it gives women the right to reside in a shared household and the right not to be evicted from the household in any condition. And it also gives women the right to seek certain remedies. Now, what are these remedies? Protection order. A woman can be given a protection order that no further violence has to occur with her. She can also be given a residence order. Like I said, she cannot be evicted from the shared household. In fact, if there's a huge emergency and she's being beaten up, an injunction order can be given so that the husband has to leave the house, but
Oh.
she will not be evicted from the shared household. There is, of course, a definition of the shared household. The shared household means the household either owned by or rented by the husband or a joint family of the husband. So that is there. She is entitled to monetary relief, for her maintenance and other things. She is entitled to temporary custody of the children, and she is also entitled to compensation if she's got some injuries, if she faces emotional trauma and she needs to seek treatment for herself or her child, she is entitled to compensation. So 5 critical remedies also the DV Act gives to the women in our country. What was your second question, Madhuji?
What are the referral protocols that needs to be followed by the first responders for victims of gender-based
So,
violence?
uh, you know, yeah, there is really no defined referral protocol as of today for a health sector response to violence. There is a very, very beautiful guidelines and protocols for women survivors of sexual violence that came out in 2014. But a lot of the states have developed their own referral protocols. What should be there? It should be based on the principles of lives that I told you earlier. Listen to a woman's story. The second is identify her needs, validate what she's saying, enhance her safety, support by connecting her to various services and providing her immediate medical care and treatment. But when protocols are being developed, referral to various institutions needs to be considered. So it has to be a joint thing, not just of a health department or a women and child development department, but various others like social justice, etc. Why? Because women, the shelter homes, if she needs to be referred there, it could be child welfare committees if it's a child survivor of violence or sexual violence. So how is it that a comprehensive first referral can be developed? Orissa has done this beautifully, and several other states also have referral protocols in place. Maharashtra has one for general violence or domestic violence. Thank you, Madhu.
Thank you so much. Thank you. So now I'll move on to Dr. Sandeep for some of the questions. Like, are there any mental health support groups or helpline? This was one question, but you mentioned about this teleconsultancy service which you just shared. So, are there any other groups?
Yeah, there are other mental health services, tele services available. Like PGI psychiatry department itself runs the telepsychiatric helpline. NIMANS has the telepsychiatry helpline, and similarly, every institute in the country nowadays almost are developing the telepsychiatry helpline services. So you can just search on the Google to find out the links. You will find the numbers available for people, and nowadays these telepsychiatric services are also available in terms of in the private practice sector.
Hmm.
So a lot of people are providing this tele-counseling services across the country.
So, in these services are free in the government setup.
In the government sector, these are free. And as I said, the initiative in the wake of COVID-19 done by the Indian Psychiatric Society is also free of cost. So, but there are paid services and there are free services. Both are available.
Mhm. Similarly, we have Dr. Neena Singla, and she can also throw some light on the help numbers available to manage gender-based violence.
Yeah, good afternoon, everyone. Thank you, Dr. Madhu. Actually, there are almost more than 50 helpline numbers which are available across the country. There are some of them are national helpline numbers, and some states have their own helpline numbers. So it is not possible to give all the helpline numbers here. I can just give the national helpline numbers. One is 181. That is a specific number for women who need any help of any kind, especially domestic violence. And then there is a women police helpline, that is 1091 and 1291. Then the National Commission for Women has also started a WhatsApp number, especially for the lockdown period. In this, on this number, you can just send a message. There is no outgoing call from this message, from this number, but you can send your message and then it's a sort of an alert. So this number you can get from the website of NCW. The link you can follow is ncw.nic.in. You'll get all the other numbers also from this website.
Thank you, Dr. Neena. Thank you. So another question is to Mrs. Anuja. How to ensure quarantine in shelter homes, which will be overcrowded as a result of pandemic?
Yeah, so if you look at shelter homes or Swadhar Graha, they are called Swadhar Graha. Uh, there is a certain setup of these shelter homes, and generally it's a dormitory kind of situation. So if we have to ensure quarantine of people that are being brought in as a result of the pandemic, people who are facing violence, and you don't want them to stay with the others, there are other rooms. So what needs to be done is to ensure that other rooms available at the shelter home get converted into a quarantine room, trying to ensure and the same thing that we are doing for our temporary migrant centers that are being set up, beds being put at a distance of 2 meters, basic requirements like bed sheets, etc., being given to women, soap, etc., being given, ensure that there's a separate toilet, ensure that the biomedical waste is put in bins which are covered, the waste, sorry, not biomedical, I'm so sorry, the
Waste.
waste that they're using is put in bins that are covered, ensure that it's cleaned regularly. So basic things that we would probably follow at a temporary migrant center, we also need to follow at a Swadhar Graha or a shelter home. There is sufficient space, and if required, a couple of the rooms can be converted into a quarantine room completely, and also an isolation room. One could be prepared in case someone develops very high fever and has symptoms for the time being before being taken to a hospital. If someone has to be isolated immediately for a couple of hours, even that is available. In fact, very interestingly, the government of Kerala has come up with a checklist and a series of guidelines, uh, on how the shelter homes should be functional at this point of time. And they have certain of these points covered. And I could share the link of that with Madhu to share to the participants later if required.
Thank you. So next question to Dr. Sandeep Grover. How can we help a pregnant woman in quarantine to deal with add-on anxiety of COVID-19 infection? I think you have covered this in your presentation as well, Dr.
Yeah.
Sandeep.
Yeah, basically what we need to understand that when people go into quarantine, usually we are putting the people in quarantine alone, that they are in a single room. Then the usual advice is don't come out, don't interact with people. Yes, physically you should not be coming out, not interacting with people. But I think what we need to be advising them that they should stay connected with the world. Now, staying connected with the world means, at least in the quarantine, those who have this facility, they should use their smartphones to all possible means in terms of staying connected with their family members, friends, talking to them, or talking to the treating team members, talking to the counselors. These are the important things. One is the connection. The second is maintaining a routine there also. That you are in a quarantine, it's not a vacation kind of time that you can sleep at any time, get up at any time, and you don't plan things because you cannot do anything. It's not that. Consider that also as a kind of a place where you can follow a routine for yourself, plan things for yourself, what you want to do throughout the day. Maybe time for news, time for hobbies, time for drawing, time for painting, listening to the music, proper sleeping time, proper eating time. Because if you maintain all this, you will know that what next you are supposed to do it. Otherwise, every time you are getting the feeling, I have nothing to do. I have nothing to do. I think that is a basic thing which kills everyone when we don't have anything to do, and when you are left alone in a room, that you cannot go out and you have nothing to do. So don't allow that feeling of nothing to do creep in when you are in quarantine. So second is, one is connection, second is the routine, and planning. I think these are three things which all is often helping the people who are in quarantine.
Very useful. Thank you. So actually, this was one of the fear in my mind as well.
Yeah.
If I happen to be go into that, because you never know. And another question is, how can we control misinformation leading to panic on social media?
See, I think it totally depends on what kind of media we are following. I think the simple thing to do is don't follow the social media too much. That's the simplest thing to do, because more you follow, more you try to see what is happening, you will get a lot of misinformation. People, those who are on Facebook, Twitter, following news, every news channel, every minute, and you talk to them, they have a lot of misinformation than those people who are not watching all this. So
Hmm.
I say having a balance of things that use authentic sources and have certain informations. And whenever you have doubts, anybody has any doubt, please consult the experts. I think if you are able to connect to the authentic center websites, it's fine. Otherwise, talk to the people who are concerned and listen to their advice, because there are certain things which are practical, but the guidelines are changing from time to time. Today morning, whatever was the protocol, in the evening the protocol changes. So whatever information was relevant 3 days back is not relevant today. So that is where we need to understand that we need to follow the issues in terms of following authentic sites, authentic people, and avoid rumors around.
Yeah, thank you. So another question is very important, that how do you, like if you're suspecting a mental health problem in a frontline health worker, which could
Yeah,
be a case, then how would you question him or her tactfully?
yeah. See, what we are like, I'm involved with the people who are in quarantine, who are doing the COVID duty. So we usually encourage people before they go to COVID duty or anything to encourage, disclose, or talk about their anxiety and worries. If they have any problem, they should come up and discuss rather than forcing them to do that kind of a duty. Number one. The second thing is, those who are in quarantine, we again keep in touch with them, discuss with them if any new mental health issues are coming up. I think the most important thing is not stigmatizing people with mental health problems is the key, because what is happening in now is that in the wake of COVID-19 pandemic, if I say that I am unwell, I don't want to do duty, people will say that I'm struggling away from my responsibility, I don't want to do work, actually that's why I'm giving an excuse of mental health or other problems. And if I disclose, then people will think that this is what I'm trying to do. But at that time, it's very, very important for mental health professionals to get involved and inform the administration, people at the helm of the affairs, that no, they have a genuine problem, they need to be treated differently, because then it will encourage people to disclose. And other thing which is happening is same thing. It is actually more dangerous that somebody who develops symptoms of cough and other things is on duty. He again goes to the same cycle. If I disclose about my respiratory symptom, people are going to say that I'm trying to run away from the duty. So these are the two issues which we need to keep in mind. If anybody is disclosing, we have to decide on case to case basis, evaluate them both mentally and physically, and take decisions. They see what happens in law when we say कि 10 criminal बच जाए कोई बात नहीं, लेकिन एक बेकसूर नहीं मरना चाहिए, वो सेम रूल यहाँ लागू होना चाहिए.
I agree. Thank you so much. So, Mrs. Anuja, there's a message for you from the participant. If you can share that link in the chat section, the Kerala link, if you have, and if you can share, then they just.
I do have it, but immediately, yes, let me try to get it. Otherwise, I will
Otherwise, we
share it
will
with
share
you
it
and
with
you
the
will share it further.
with the attendees. So, I think that two, just one
I
last
will share
question.
it definitely.
Okay, one last question to Mrs. Anuja. How can you ask about domestic violence from a woman who is living in one room with many others?
Yeah, we need to talk to a woman in confidentiality, in privacy. When we have to talk to her about violence, because she may be facing violence from one or couple of the members in that room. I think the best way to do this is to, take her outside, take her to another place in the pretext of doing some checkup. I mean, such a situation would probably come up in a village or a small town. And when an ANM is visiting and she's been told by the woman survivor that, or hinted that, yes, I am facing violence or something, and she wants to talk to her, she wants to seek remedies. So then it's probably the duty of the frontline functionary to take her separately in the pretext of probably checking her or doing an examination and talking to her and trying to link her to services or support that she can. Because otherwise,
Yeah, thank you.
there
Dr.
is
Madhu,
really no way to
Yeah,
talk to a survivor when everybody is present.
sorry, Dr. Madhu, I would like to add something to the referral linkages.
yeah,
Uh, when you get a person with domestic violence, the person, such a woman will come either to the hospital directly, or she will go to the one-stop center. One-stop centers are being advertised everywhere these days. So these are the two places that the women will go to first. So if a one-stop center, the person goes to the one-stop center at the first instance, then those people should have all the hospital numbers. They should have a proper linkage. And if she goes to the hospital in turn should have numbers of the one-stop center. So each place can have its own protocol in place. They can display those numbers for the residents. You can display those numbers. This is the place you have to call whenever a person with domestic violence comes in the hospital. So when the patient comes, they'll call the one-stop center and they'll coordinate with the one-stop center. They send a counselor and they inform the police also. And if she goes to the one-stop center first, from there they have an ambulance service. They transfer the patient in the ambulance to the hospital. So there can be a local linkage also, and that should be displayed. One-stop center should have the display of the hospital, whatever linkage is there, and the hospital should have the display of the one-stop center. What I have seen is that there is no coordination between the one-stop centers and the hospital. So that is the problem which arises most of the times. The counselor doesn't reach in time, and the person, she doesn't find shelter in time. So these are the problems which arise mostly.
yeah. Thank you, Dr. Nina. I mean, that's a very good point. So, one last question to Dr. Sandeep. How can we suspect a pregnant woman is suffering with mental health problem? And once you suspect, when will you decide that she needs to be referred to a specialist?
Yeah, I think I alluded to this briefly in my
Yeah,
presentation,
yeah,
that
yes.
when you're talking to a woman and you are suspecting certain issues, especially that she is not gaining weight properly in the ultrasound, you're finding the low birth baby is there, or the baby's size is smaller, she's not able to sleep well, not able to eat well, reporting a lot of physical complaints. I think that is the woman who needs to be referred to a psychiatrist. In terms of anxiety, I think one simpler thing, when you think that somebody is asking you too many questions, as a doctor or as a clinician, you know that the person is very, very anxious. I think that's a simpler thing to understand, that if you're dealing with somebody who is very, very anxious, will have much more questions for you than a normal person, or he or she may end up asking you the same question again and again. So if you just remember these certain behaviors, I'm not going to the symptoms per se, you know that these are the people who requires evaluation and maybe further detailed workup in the hands of the mental health professionals.
Should be referred. Yeah, thank you so much. So we had this last question, I think, from the attendees to Mrs. Anuja. What do we do if, in case the survivor doesn't want to file a complaint, but the injury is quite severe?
Okay, one thing we need to understand, that at no cost can a hospital, be a public hospital or a private hospital, deny treatment to a woman, who has come, a woman survivor of violence. So that is one thing very critically. Several times a woman may not want to file an FIR, even in extreme cases of a sexual violence. So in those cases, you have to tell her that for us, it is mandatory to report cases of sexual violence. I mean, confidentiality, yes, but there's a limit of confidentiality. There is mandatory reporting as per both the criminal amendment law and POCSO, but you cannot deny her treatment. Very clearly, Section 357C of CRPC and Rule 5 of POCSO says that it is compulsory for a doctor or hospital to provide a treatment, whether the person wants to inform the police or not. In cases of sexual violence, FIR, maybe she does not want to do, but you have to inform her, it is mandatory. Document informed refusal and still file a medical legal case. But under no circumstances will medical care or treatment should be denied to a woman survivor if she approaches a health facility.
So in that case, is it the responsibility of the hospital to inform the police? if the case is like that?
In cases of sexual violence, yes, mandatory reporting is necessary. So, under the Criminal Amendment Act, under POCSO, it is the responsibility of the doctor to inform the police. Mandatory reporting is there.
Yeah.
Again, we say consent has to be taken. If she's absolutely not willing to inform, refusal has to be documented, but still a medical legal report has to be filed. So that means informing the police in some way. Confidentiality, yes, but there's a limit of confidentiality that the survivor needs to be told.
Yeah, yeah. Thank you. That was really interesting. I think both the sessions really went very well, and we have a lot of comments from the attendees. So, with this, we end this session. I'm really thankful to Mrs. Anuja, and I'm sorry, she was earlier working with UNFPA. Now she is in Delhi working on gender, working with gender group.
That's
Yeah, and I'm really thankful to Dr. Sandeep Grover for his lucid talk and taking out time for this webinar. And I'm thankful to Dr. Neena for to be here as part of the panel discussion. Thank you.
Thank
Thank
you,
you,
everyone.
Dr.
Thank you
Madhu.
so much.
Thank you.